Hi everyone. So thanks so much for joining our very first Guy's and St Thomas's private healthcare events and education webinar. So this is a new programme for 2021 and it is designed for GPs and healthcare professionals. So the first instalment is actually dedicated to women's health, and that's what our webinar will be about today. Our webinar is on preconception and it's all about the holistic approach. So just starting with a few house rules. So just in terms of Q&A, if any of you do have some questions throughout the webinar, as Jess is speaking, you please enter any questions that you do have using the Q&A button. If we do get a few questions, if you would all be so kind to just actually vote on which questions you would like to be answered first, we can use an upvoting system to get those all sorted. Also, in terms of feedback, after the webinar, you'll receive a short survey that should just pop up straight after using Zoom. We really appreciate any feedback that you can give us, and it will really help us to improve any future events and services for you. And just in terms of certificates, so all certificates of attendance will be issued within a week of the session. So we'll make sure that they're all emailed out to you. Just make sure that you do check your junk email box, and any issues you can just get in contact with us. So just a brief overview of us at Guy's and St Thomas's private healthcare. So we do offer clinical excellence in the heart of London. We offer many different specialties, including women's health, which is what we first spoke about here in terms of the webinar that we're offering. This includes maternity, fertility and gynaecology services. We also offer pediatrics and adult services as well. We have a wide range of different services that we can help you with to refer to our consultants, and you can visit our website just to have a look at what we've got there and what we have on offer. And what I'd like to do is introduce Eniko, who's our head of women's private services, who's just going to go through a bit more in detail about our women's services and what we do offer at Guy's and St Thomas's.
Thank you very much, Monique. Yes, I just thought I'm going to do a really quick introduction. So I'm looking after private women's health services in Guy's and St Thomas's. The reason we created this platform because we wanted to share the amazing knowledge and expertise we have in a hospital. We are one of the only NHS trusts that we have women's and children's specialty services under one unit, which is a unique opportunity to provide high quality integrated care for mothers, babies and children. We have multiple consultants who have expertise specializing in women's services. On gynaecology, we have seeing 6,400 patients on a yearly basis, and now we have an amazing private facility on Wimpole Street where our consultants seeing private patient and offering gynaecology services. On maternity services, we have around 6,000 birth rate on a NHS site and around 350 births on a private maternity unit where we have 6 inpatient beds where we can look after private patients. And our fertility unit, the AC or assisted conception unit, has been established in 1991. So it's one of the largest fertility unit where our consultants continually looking after patients and focusing on research and innovation in fertility care. Monique, would you mind going back to the previous slide? Sorry. So our seminars or women's healthcare seminars very much focusing on providing knowledge on all 3 services. And we try to bring you women's health related services on a monthly basis, either fertility, obstetrics or gynecology. So please look out for these topics. And today I just would like to hand over to Jess McMicken, who will provide the first women's health seminar. Thank you.
Oh, sorry, just my video. Thank you very much for having me, and welcome everyone to our first one this evening. It's lovely to be invited first up. Hopefully it goes well because we'd like you all to attend more that are put on by my colleagues. But But yeah, so what I'm going to speak about tonight is obviously preconception and looking at the holistic approach. In terms of my background, so I'm a general consultant obstetrician and gynecologist. So I guess in terms of this talk this evening, what I've tried to do is gather a bit of everything, which is obviously useful as both a general practitioner for any midwifery colleagues that might be listening tonight, as well as from a consultant obstetrician and gynecology perspective. So looking at it broadly, I know that you've got some seminars coming up where my more specialized colleagues in fertility and whatnot will be able to contribute their knowledge to this. But tonight's keeping it simple, but keeping it holistic in approach. Quick background, so you may have guessed I'm from down under, so I trained in Australia. I've been in the UK at St Thomas's now for 5 years. I'm one of the consultants there, and I also do private practice in both obstetrics and gynecology. And I really enjoy this perspective of both aspects of my NHS and private work, and that's looking at women, their respective partners, and the holistic approach. I have no disclosures to make. In terms of my personal thoughts on preconception, I mean, you probably should disclose, do I agree with it? Of course I do. When I think about it, I couldn't imagine embarking on a pregnancy without knowing everything. And I think that's what's important. And I know friends, colleagues, family, often ask a lot of questions. And I think that really points out that, we need to give our parents to be, the time, the high quality information, and also that level of support so they enter a pregnancy with this amazing set of knowledge. And so importantly, they feel safe and comfortable. And that's what I always say to patients, it's my priority that you enter your pregnancy, all throughout your pregnancy, you feel safe and comfortable. So what am I going to look at? Well, very quickly, we're going to touch base on the objectives of the preconception appointment, because some people might go, well, what's the point? Surely you can read something. But there are a lot of objectives to the appointment. And I know I'm seeing an increasingly number of couples that, want that aspect of it before embarking. Very quickly, for those that don't know the mechanism of how to fall pregnant, we'll touch on that. And then what I'm going to go through is a few different themes for preconception and touching on that holistic approach. Briefly at the end, talking about assessment. And then I thought it was quite interesting, from a general gynecology and obstetrician perspective, when do I call on my colleagues? And I think that's also important when you're in the general practice world, as well as knowing, when is it okay to, refer patients on for help. So what is the objectives? And actually, NICE, Public Health England, they all very much agree with the preconception appointment, because they actually think that what we should be doing is giving this to all women, not just public or private. It should be across the board, because what it's going to do is address the long and short-term health outcomes for not only a woman, but her offspring as well. Why is it that will happen? Well, actually, what it does is it says, okay, we can go through your risk factors. We can modify things before one embarks on a pregnancy. We can then actually educate patients so they can make informed decisions about their pregnancy. Is it safe or not to fall pregnant? And also it ensures that we keep looking forward, and what they say is leads to a healthy lifestyle, not only for that couple or that woman, but hopefully that then rubs off into the respective household. So these are a few different statistics. I'm going to use a few infographics that you may or may not have come across, but they are always very, very powerful. Now, the first thing I think Public Health England have identified is actually, when we look at pregnancies, a lot of them are unplanned, or, people enter them feeling, oh, I don't know, is this the right thing to do? And I think this is the audience we need to be capturing. We also know that there are women that enter it without that broad base of education. In particular, if we look back the clock at 2011, what was published was actually 1 in 3 women were on folic acid, which is a huge thing we need to improve on, because we know of those improved outcomes in pregnancy. What we look at here, we've got to think about the impact it has on a woman, and then also the children. And so going forward, what this appointment needs to be is very individualized. You can have your checklist, but actually at the end, when you're summarizing it, you've got to make it individualized for that patient and keep that broad sort of overview as well. The conception mechanism, and I'm only just putting this up here because I know, everyone knows how to fall pregnant. But what we've got to understand these days is obviously there is a different makeup of how to fall pregnant. We need to consider that, a lot of these pregnancies may have assisted reproduction along the way. We may have sole parents. What we've got to think about is there are different ways to do it. And so therefore, when you approach your appointment, you've got to keep an open mind. In particular, it's knowing, what is the background, how did they fall pregnant, how do you fall pregnant, what is the diary got to look like, what is the diet, requirements as well, what is their baseline weight, all those sorts of things. It's thinking broad and approaching it in that manner. So in terms of success, and often, we do quote this statistic to couples, and I must say, I have a lot of friends that are frustrated by this because they're like, oh, we hear this from everyone we go and see. But when we think about, okay, well, what are your chances of falling pregnant? It's a really easy statistic to remember, out of 100 couples, 80 of you in 12 months, and then in the subsequent 12 months, half of the leftover will fall pregnant. And yes, it can be really frustrating if that you're that small minority in the end that don't fall pregnant. But that's obviously when the alarm bell set and we can offer them help. So we're going to start off with the basics first, dietary advice. What do we advise in that preconception period? Well, it's actually all about just maintaining a really healthy lifestyle. And obviously what that is just, you're ticking off, that rainbow plate, or, that really well-balanced sort of nutrition, whether that encompasses, eating red meat, incorporating your fish, your fruit, your veggies, sticking to whole grain, adopting a low glycemic index, and then looking at, your dairy products and ensuring that they're low fat, low calorie, low sugar. In particular, what we can also say to our male counterparts, if they're part of a couple, is actually there are some foods proven to improve one's sort of sperm motility and count as well. And that's looking at incorporating zinc and selenium into one's diet. The NHS Food Scanner app is actually really useful, and that's something that I've been able to share with patients, and actually it makes their food choices much, much easier. Caffeine. Now, caffeine's an interesting one, and there's been a lot of, I guess, attention on caffeine, I think, especially in the last 6 months. And that's because there was a paper released in 2021. All my references are at the end as well, if you do want to take a read. But basically what they're saying now is actually we should be limiting one's caffeine intake to 200 milligrams a day. And so if we look at it over here, actually, you can sort of see, probably the coffee that we're fed in the hospital, you could probably get away with having 2, but actually if you're having that really strong shot in the morning, sticking to 1. Now that's in pregnancy itself. Why we say consider it all together during preconception is we're just still not sure, what's going on. And actually what we sort of dwell upon is this miscarriage risk that can be associated with caffeine. And of course it is dependent on the dose. So you can see here that sort of, you start off at 100 and then milligrams, it's got the 7% risk, and then it goes up. But that's sort of, I guess, the downside of it. And hence, in a lot of literature, they say if you can avoid it preconception, that's actually better going forward. In terms of alcohol, this is also, one of those ones you probably do often get asked a lot. First of all, if we look at our statistics, actually, we should be quite proud as a nation, because actually what we've found, this is also pre-COVID lockdown, but what was happening is our alcohol consumption as a whole was reducing, and that's across, both genders, but as well as our women. And that's really something that's quite positive going forward. What we know is, unfortunately, there's a lack of clear evidence for what's a safe threshold, and that applies to preconception and pregnancy. And so what we say is actually, the safest way is just to avoid it, to keep those risks at a minimum. We know that alcohol can be linked to things, so in particular infertility. So it can slow down one's sperm. It can lead to having sort of an anovulatory cycle. It can lead to miscarriage. And then, of course, there's those pregnancy complications after that. So, with chronic consumption or binge drinking, obviously you're moving towards that fetal alcohol syndrome, but also can affect that fetal development. And so what we've got to remember, that baby in that first sort of 12 weeks is really developing those organs. And so actually that's especially important that one avoids alcohol in that time. Oh, I was meant to say in the corner, prompting me is, you must know these days there's actually some great alcohol-free drinks available. And I often put up sort of Instagram posts on my Instagram account for my private practice, and often I cross, to general sort of topics. And one of them recently was about alcohol, how to avoid it. What do you do if you're going out? What can I drink? And these are probably the most popular. Well, some of them. I'm not getting sponsored by anyone right now, but actually the Seedlit Gin is a really good one, and it's often available at a lot of places now. But you can also drink it at home, of course. And then, of course, you've got a lot of alcohol-free beer selections. You can obviously get alcohol-free wine, but I think the reviews on that aren't so good compared to these ones. Smoking, okay, well, what do we say to smoking? Do we say, oh, okay, just cut back, that's what you're doing? Actually, we shouldn't. We should be saying, stop smoking altogether. I'm going to support you doing this. I'm a health clinician. I've got all this support at my fingertips. And so why do we say that? Well, we know it comes with so many risks. Not only, does it affect that sort of preconception stage, falling pregnant, we know it can lead to miscarriage. It's a risk factor for ectopic pregnancy, but then going forward, it combats with a lot of long-term risks to that pregnancy. As a health clinician, adopting this approach to smoking, actually, well, you've got to approach it holistically. You've got to start off from scratch and say, well, why do you smoke? What is it that, made you start smoking? Because that's actually your key in helping that patient stop altogether. As you know, as a GP, I'm sure you know these referral pathways, where you can reach out for help. And then, of course, what you've got to think about as an individual is, how can I support this woman and possibly her partner in supporting them and their smoking cessation going forward. Vitamin supplements, so folic acid, and this is obviously, one of our most common ones that we all know about. The dose, what do we give them? Well, actually, we've got our standard dose, 400 micrograms per day. We're meant to be starting it at least 3 months before conception, and that's just to make sure that it's in the system, a woman's taking it, she's compliant, because what we're trying to do is ensure she's on it for that entire first 12 weeks when that baby's developing all its neurological structures. Of course, we've got that subset of women that need that high dose. And in particular, I've just named a few of those examples. It's women who are obese, they're on that anti-epileptic medication, or they've got a malabsorption disorder that may impact on that absorption of the folic acid. We know it's proven to reduce the risks, and this is across, the Cochrane reviews as well. And so what we're looking at is taking folic acid, you're tackling it from the primary prevention, but also in those women who have had a pregnancy affected by neural tube defects, it's preventing a recurrence as well. This is the statistic I quoted earlier on that earlier slide. We've still got room to improve. And so hopefully over the last 10 years, when we've got new data released, we'll show that actually, it's not just 1 in 3 that are on folic acid now, it's much more higher proportion. Vitamin D, and I think this is a really good one, because even as a non-pregnant adult, we need to be aware of the recommendations. Across the United Kingdom, in winter, we just don't get that sun that we need in order for our body to obtain vitamin D. And so actually, all adults in the UK, and this is something to tell couples who are trying to fall pregnant, between September and March, we actually should be taking our supplements. If you're pregnant or breastfeeding, regardless of the time of year, you also need to be on supplements around the clock. And that's just that standard sort of 400 international units. If you've proven to be deficient or you're classed at high risk, we need to give them a much higher dose. And it can be 1,000, but it can actually go up to 2,000. That's obviously depending on their vitamin D levels. Why? We know it's essential. So as an adult, we know that we actually need it most importantly for our bone health. But in particular, when we're growing a baby on the inside, we obviously need that baby to develop its strong bones. Some might say, I think I'm getting enough vitamin D from the sun. Well, actually, it's really hard, and you'll see debates. I know in Australia, we used to say, and probably because we've got that hole in the ozone layer, that actually 30 minutes is enough. But when you're in the UK, actually, we just don't know what that is that our body's absorbing. So we actually have no idea how long we're meant to be sitting in the sun. We've all got different colored skin. And so it's hard to know, what our melatonin is doing as well. But in particular, when it's winter, those rays aren't just enough as well. And so that's just important in going forward. From a multivitamin perspective, and I recently put up a post about this, and everyone finds it quite interesting because actually it's not compulsory to be on a multivitamin. Why it's a bit of a safety net. It contains a bit of everything. So what I always do is, when I say to women, oh, what are you taking? Are you on a multivitamin? I make sure they take a photo of it, and show me next time they're in clinic, or they can send it to me. And it's important to check, what amount is it? Is actually, most often it does contain the right amount of folic acid, but you should be checking. I think what's important is to look at the iron content as well, because often women are sort of in this protective layer. They're like, oh, but my multivitamin contains iron. Well, actually, if you read the label, it's actually not necessarily very much at all. And especially if they're anemic, they actually need to be on more. It's important, though, to think, okay, well, if one wants to be on a multivitamin tablet, actually, are they at risk of needing increased nutrients? And that's them thinking outside the box. Okay, this lady's vegetarian. Yes, she needs to be on it. Well, there might be something else going on, or she, might have had a short interpregnancy interval. Her body is just not quite recovered. And actually that, potentially is a reason for her as well. And so it's important exploring all those. And actually, that safety net is if you don't think they're on a well-balanced diet, just give them a multivitamin. Body mass index, and this is from my nutritional background, this is always sort of one of those topics I love to discuss underwater. I'm not going to spend too much time on it tonight, but it is a really important one we address. And why is it? Well, actually, if we look at England, we're not doing so well from the BMI perspective. And I'm sure all of you could actually tell me this from your own practices. So what we know is actually a lot of women are entering our pregnancy now overweight and obese, and that carries with it so many risks. Once again, it's looking at the conception, the pregnancy, and even postnatally. The list will go on, and I haven't hardly even touched the surface of what I've written on this slide. What we know is actually preconception weight loss is actually not bad, and it's far more favorable to do it then than therefore saying, oh, actually, this needs BMI, can you not gain so much in pregnancy? What we've also got a lot of information now is about this fetal programming. So when someone, conceives and forms this fetus on the inside, what we're actually putting a stamp on is their body metabolism going forward. And there's this huge link now with obviously obese adults, childhood obesity, it goes on, and those metabolic disorders. And so that's why it's really important. We want that fetus to have this ideal programming to set that baby up for a much healthier lifestyle. So what we say is actually we should be delaying conception until one can achieve a healthy weight. And yes, it's a really hard body mass index sort of range to achieve. And yes, one might argue that BMI isn't, the end all, but actually that's what we should be doing as healthcare individuals. If women are on a BMI of over 30, well, actually what we should also be telling them is if they were able to lose a little bit of that weight, it's going to lead to a much healthier pregnancy, and that baby will be better off long term. As health individuals, we need to use any opportunity we can to not only provide them with this information, but support them too. And so actually what our NICE guidance and Public Health England are suggesting is actually we should be encouraging them, weigh yourself, take waist measurements. There's so many apps now where they can record that and show you this data when you see them. We also should be signposting them to our weight loss support programs, and also then tailoring target goals that are within their realms as well. So we know stress, redundancies in work, that can all fuel a more unhealthy, or it can go the other way, but it can have that tendency, in some women to sort of have that emotional eating or be put off exercise. And so it's really important we're sensitive to that as well. And we must be keeping it realistic. And so it may be that actually, for this woman, losing 1 kilo a month is actually more realistic, and probably is about the average anyhow. But for someone, it might actually be even harder to achieve that. And so it's really important you be sensitive. What we also say is if you're going to lose weight, actually, then we want this stable sort of time period, because actually what we want to make sure is one's nutrients, we're not deficient in everything, and actually we're entering our pregnancy in a much sort of better sort of perspective. Exercise. Okay, well, what can we say about exercise? And this sort of tabs on from the body mass index. We know it's got these huge benefits. In particular, your exercise combined with your diet is going to help you achieve a healthier BMI. And so what we know is also when you enter pregnancy, it's got all of its benefits. It's not only looking at that body mass index, but it's actually helping a lot of pregnancy associated symptoms. In particular, it's building up one's core strength that will help with back pain, all those typical type pregnancy symptoms. It'll help keep those bowels active, you name it, it's on the list. And so what we should be recommending is actually, thinking about, okay, well, encourage one to try and exercise, 5 times a week, 30 minutes a day. Obviously, if they're starting off on a baseline of no exercise, it's once again tailoring and saying, look, each week, can you walk 10 minutes longer? That's a really easy way to do it. And also, there's these wonderful apps now, and these are 2 that are actually endorsed by the NHS. They're Active 10 and Couch to 5Ks. Really good motivators, free. Everyone's got a phone now that can play an app, and they're really good tools to help encouraging. Medical health. Now, I'm not going to dwell on this, and I know probably the blurb of today said we're going to talk a lot about medical conditions, but in the essence of time, because we've only really got 40 minutes today, all I can say is, there are going to be lots of specialists that we're going to be able to, hear from over the course of these women's health seminars. And what they will do is sort of talk about these chronic medical health conditions and point out, well, when we look at a medical health condition and we say, okay, well, preconception, what are we going to do about it? We've got to think about, well, how will that condition impact on the pregnancy, and how will the pregnancy impact on that condition? And this is just taken word from one of my wonderful colleagues, Professor Nelson Piercy, and she's obviously published this book. I'm sure lots of you know about it. I use it to study for all my specialty exams, even in Australia. But it looks at all these medical conditions and provides really good counselling and checklists as a clinician that what we should be going through. What we need to be doing is obviously obtain that thorough history of the condition. So look at when it was diagnosed, what has been done, who's been looking after the patient, what can we do going forwards. It's important to address all those, because what you want to do is optimize the health of the mother. And when we look at our embrace data, what we can see is actually when we look at the, sad little group of women that unfortunately suffered from mortality in pregnancy, 2/3 of them had a pre-existing medical condition. I will though touch on, just for example, diabetes, and this with myself within our diabetes and pregnancy service at Guy's and St Thomas's. What we know, and preconception wise, it actually it's affecting, the data says in the NICE guidance, up to 5% of our pregnancies, but actually it's much more on the increase. And I think we blame a lot of the COVID pandemic, and I know at St Thomas's it's around about 10 to 12% now, and that's because we're picking up on a lot of gestational diabetes because of the lifestyle changes. But this is some of our more recent data within the UK, and actually you can see that type 1 and type 2 are on the incline, and these are the women that you're of course going to be exposed to in your practices. Important thing preconception is obviously optimizing that glycemic control, and that's because we know that high levels of glucose have a really important impact on the baby, and that's especially when we look at neural tube defects and congenital heart defects, it can really impact, and it's all about what our HbA1c is. When we assess them, it's important to do that holistic approach. So it's, finding out together as a team, okay, well, who is their endocrinologist? Because that person's got a huge role in their pregnancy. We don't look after pre-existing diabetes as a solo condition. I wouldn't even do that as an obstetrician. It's as a team. And that's obviously incorporating dietitians. It's working out, does this woman need to consider bariatric surgery? And then of course it's doing that baseline assessment preconception, getting that ophthalmology review, and then of course checking out our renal assessment through the use of bloods and urine as well. Medication. it's too hard to talk in a few minutes about medications, but as you know, you all know, it's really important to review it. And the reasons being is we want to know, well, actually, is it safe to go on with those? We've obviously got, you know, those common medications where actually we've got to think of alternatives for them. And if you're unsure, you would never get in trouble for referring to a colleague or specialist. There's also really helpful, and this is probably, I think, the most useful one I find, is our BUMPS resource on the internet. And that looks at best use of medicine as well. When we look at it, you know, we've got to look at our Embrace report, and it's important that actually we can't just stop a medication, you know, preconception or early pregnancy, without thinking about why it is the woman it is and consulting a specialist or colleague to help support that woman. Because there are particularly important medications, especially, you know, what comes to mind is our anti-epileptic medication, that, you know, there's a lot out there that says they're bad, but actually if you read between the lines, they are safe to take in pregnancy, and they actually are important for that woman's health. Cervical screening, this is another one often you get asked about. What do we do? And this is all as per our NHS guidance. You know, we know our cervical screening program, you know, when we commence it, that we need to screen every 3 years. If one comes to you thinking about falling pregnant, always ask, you know, do I need to take a pap smear test? Because this is the perfect opportunity to have it performed. You know, if they can tick that thing off, they don't even need to worry about it postnatally, you know, when they've got a newborn. If one's due for routine screening, and especially in that early pregnancy, so someone might come to say, oh, I think I'm early pregnant and actually I'm due. Well, actually, you know, we can perform cervical screening, but most women are actually encouraged, and we don't necessarily mind as per guidance if they do delay it postnatally. But it is safe to perform. It can just be obviously a little bit technically difficult the later you leave it. Some women just choose they actually don't want you touching their cervix because that just to them sounds alarm bells, and that's completely fine. You know, we've got to respect their decision, but also our cervix can change a little bit of nature. Of course, if you're going to delay it, you need to know, well, actually, what's a woman's screening history? Because actually, is this safe? You know, is she someone in the background that actually needs this 12-monthly assessment? And that's obviously important to take forward. Immunisation status, we've got, you know, our main immunisations that we need to be aware of. And of course, you know, that's looking at our rubella, our flu vaccination, the most common thing we get asked about at the moment, our COVID vaccination. And of course, I've put in here our national guidance. This is the best tool. I always signpost patients to it. I think it provides a really good summary of why someone is debating a vaccination, and just puts it, you know, very realistically what they need to think about from both sides of the fence. Of course, whooping cough, that's another really good one. And so it's important that, you know, adults sort of think about, if they're entering pregnancy or they're going to feel pregnant, actually, well, when should I be having a whooping cough? Do I actually need it as well? Previous obstetric history. So it's an important topic to explore. So why it is I think there's, you know, a really big space here for us to do better at this. I think, you know, coming through, we have a large group of women who, you know, are possibly, you know, having very difficult pregnancies, whether that's to do with the COVID restrictions. Their delivery has been slightly changed by that as well, but also postnatally, they may not have felt they had the support mechanisms. And actually what we want to provide is that level of support the next time around that they didn't necessarily get. And I think I always do tend to ask this very question if someone gives me preconception and say, oh, you know, it sounds like you had a wonderful pregnancy. If there's something that you could change though, what would it have been? Because I think that's really interesting. It might be that they say, oh, actually, you know, I wanted a more face-to-face appointment, or, you know, when I went home, I didn't know when I need to see my GP, or things like that. Or it could be, you know, to do with a big theme that you haven't yet explored. And so I think that's really important looking back. One of our big emergency issues at the moment is traumatic delivery. And actually what I've quoted here is a Southwest England study, and the reference is in the back. But what it actually looked at sort of about 250 women that's given pregnant over, you know, the last wee while. And 1 in 3 actually experienced a traumatic birth. I think that's really powerful. I know this is self-reported data, and obviously collecting that cohort, you know, there could be biases, but still 1 in 3, you know, it's something that we really need to reflect on as a whole, and obviously make improvements going forward. Of course, there's the whole perineal trauma, which I see a lot of now as well. And it may be as simple as, getting the notes and going back through. And that's probably more from an obstetrician point of view, where we recall wherever it is this woman had a baby and go through it step by step. But it's important to know, okay, well, what went on down below on the perineum? Do I actually need to examine her? Should I be looking for scar tissue and those sorts of things? And I think, if we can provide a thorough assessment, and even if it's reassurance in this period of time, that woman's set up a lot more for her pregnancy. So what does my assessment typically involve? And so I must say, I do have a bit of a template, but that's just, for myself. I've got a terrible memory. I don't want to miss anything at all. And I find I get distracted very easily by all sorts of things. But I do have that. And it's important that you focus on that patient history for a good amount of time. Like, you've got to be thorough. You've got to go through everything. Going through family history, super, super important as well. Examination wise, this will depend on what the organ specific, nature is. And so you may find your examination components quite small, but it should always include weight, blood pressure, body mass index. I think they're, the bare minimum as well. And then of course you want that discussion at the end, and whether it's a follow-up consultation, because obviously we've got limited consultation time, or whether, off the cuff, there's going to be these generic ones. And then I think it's important, saying whether it's on a letter or going forward, you have that discussion. Okay, well, this is our plan of attack. It might be that you say, what, I heard you today, you're really healthy, I'm really excited for you both, I'm going to write a letter, there's nothing more I can add at this stage, but what, follow-up wise, this is what I recommend. And that's really important. You want to close that circuit and make that woman and her respective partner feel sort of comfortable and safe. Touching briefly now, well, okay, this is your forward plan. What are you going to tell them about having sexual intercourse? And I think, the key, if we look across our guidance, is actually unprotected and regular intercourse is actually the key. We always talk about this fertility window, because we know that actually, when we look at it, there's obviously a time where one ovulates. And what I always say quite, briefly to patients is, sperm hangs around, but the egg doesn't. And, we know that from a sort of a lifelong, the sperm has this 5-day life, whereas the egg, goes and, that's it. And so, interestingly, some of our guidance says there's no need to plan intercourse to coincide with ovulation. And actually, if you look at some of our unplanned pregnancies, this is exhibit A of what happens. Someone might spontaneously ovulate, really strange time in their cycle, and say, hang on, but I wasn't meant to do that. Actually, that can happen. They say that it doesn't necessarily increase the chances of success in, this guidance, but it can lead to stress for a couple. In saying that, we know there's a fertility window, and so I think you can take that sort of guidance with a little bit of grain of salt. Sexual position, there's no proven scientific one, but what we can think about from a practical point of view, well, actually, if we can get the sperm as close to the cervix, possibly that will optimize one's chances. I guess if we also look at women's wives' tales, where they say, if you lie on your back for, half an hour after sex with your bottom on a pillow, gravity will help. That's another one that's actually not necessarily medically proven, but it doesn't harm anyone, and potentially, I guess, that may have worked for some women in the past. I think it's important as well to stress to couples, don't make this feel like sex is mechanical. Try and actually make something of it. Book a holiday, go away, forget about it for a while, because that actually might be, in that fertile window when you actually may fall pregnant. And then this is a really interesting one, and I think this is becoming more and more prominent, is actually patients can help track these things these days. So in particular, there's lots of fertility tracking apps, and actually there's a recent publication about this that said there was 206 on the market. They actually only looked at 106 in the end, but they found over 200. And some just track dates. You sort of enter it in, and some cost money, some don't. But women are prepared to do this. They want to help you in getting them there. And one of the benefits of it is actually, it points more awareness of one to what their cycle does. Is it lengthy? when does it occur? And obviously by tracking your menstrual cycle, I mean, you're not finding out when you actually ovulate, but it has its benefits of, you know, someone might not realize they have an irregular cycle and they could have polycystic ovarian syndrome until they track it on an app. So that's where it can be useful. We've also got these ovulation predictor kits and tricks where you know, one can buy them on Amazon. Clearblue's probably the most common one I've come across. I'm not at all sponsored by them, but it's just a common one. And so what happens is a woman can dip her own urine, and obviously it's looking at that luteinizing hormone, and it comes up with sort of a smiley face, a frowny face, all those sorts of things. And so it detects that sort of ovulation or that surge in the LH. When we've sort of looked at it from a you know, research perspective, it's shown that actually between users and non-users, it hasn't actually affected the clinical pregnancy rate. But I think in time, you know, maybe this is something evolved. Remember, some of these research, you know, what we're looking at, the data, it is a little bit restrictive. And so, you know, it's once again not harmful. Maybe it will prevent stress, but actually maybe it's something that one can consider utilizing. And lastly, when do you refer to a fertility health specialist? And I think this is an important one. And I think one should never feel ashamed for doing that at all. And I know I certainly don't. I love my fertility colleagues because, you know, we want to help these people. Infertility, by definition, you've always got to think of the definitions. And so we know that, you know, it's after 12 months of trying, it affects 1 in 7 couples. NHS funded fertility is an interesting one. And I mean, we're really grateful that we have this service within the NHS, but it actually, the criteria, it can be really strict. And it does depend on your local CCG of where you're located in London and what their cutoffs are for age, body mass index, all those sorts of things. And this is just one sort of example here about, you know, if you're NHS funding, what you're actually ticking in that box. Of course, then you've got your private fertility treatment. And I guess, you know, some couples have that opportunity to utilize it and have, you know, the finances that can make this an option. And obviously, you know, you can therefore, you know, refer them at any stage. I guess it's important, though, to remember those red flag couples, because I think they're the ones that actually we shouldn't be waiting the 12 months for. And I'm sure, you know, you're going to hear from my fertility colleagues in the months to come. But looking at that subset of women who are of an older age, they have reduced ovarian reserve, they're known to have, you know, irregular cycles. You know, these are the women that actually, you know, they need this earlier help. And it's important to identify those so that, you know, we don't get to a stage where their clock has sort of ticked a bit too long. So we're going to leave it there, right on 1:45. I did promise. And so we're going to take the floor to any questions now that people may have.
Yes, Jess, I think we have 3 questions. I'm sure we're going to have time for all 3, so we don't really have voting on it. Hina had a question. What is the view on risk over 35? Are these studies now outdated?
Risk over 35, and is that from the pregnancy itself or from other realms? I think it must be from approaching pregnancy, potentially. I'll answer it from that question. I guess it's that age thing is an interesting one. And actually within London per se, you know, we do have a subset of women who enter pregnancy at a more advanced age. And I really hate that term. And I never use geriatric pregnancy because I really cannot stand that. But I think what we know is we to be honest, we can't take away, you know, a pregnancy from a woman who's 40 and has had worked and, you know, is entering pregnancy at an older age, because once again, she actually may be of a medical health that actually is something that reflects someone of a much more youthful age, but also she is entitled to, and we, you know, for her own personal choice reasons, we can't take that away. We know women 40 years and over do take with them into that pregnancy some additional risks, but we have things that can reduce those risks. And of course, you know, I'm thinking off the top of my head, the use of aspirin to help that reduce the risk of preeclampsia and hypertensive disorders and placental insufficiency. And actually, you can still put together a safe pregnancy plan with surveillance to look at those women. And I think once again, it's tailoring it to the individual, which is a big thing. I think there'll be a lot more data to come in this subset of women, and especially in embrace data as well, because obviously when they've looked at the outcomes and they've looked at the age subset, you know, a lot of these, you know, risky pregnancies are from older women, and that's just because of the potential sort of medical comorbidities that they bring to the pregnancy with them.
Yeah. Thank you, Jess. There's a really interesting question from Charvani Collinson. Do men need to watch their caffeine intake as well?
Yeah, actually, it's true that there is data that men should. Now, I think what we've got to understand is actually, you know, as much as we say, oh, it always seems to come back on the woman here, you know, she needs to do all of this. It's not at all. It's if, you know, a couple is made up of a male and a female, the male needs to be making an effort with preconception in particular. And looking at it, they actually do say that from a caffeine perspective, you know, caffeine can impact, you know, on one's own sort of body. You know, we know it's got that sort of vasomotor drive, but also it can, you know, have that impact on sperm and the motility of the sperm. And that in particular, probably if we look at it, alcohol probably has the biggest impact, but they do actually say from a caffeine perspective, you know, it's a good chance for the male, you know, to reduce it down. Doesn't need to withhold it completely from the diet, but it is a good chance to cut back on it, yes.
Thank you, Jess. I'm glad Susie asked the question regarding postnatal trauma. Is there specific trauma-induced postnatal anxiety society or counseling out there?
Sorry, you might have to repeat that. Sorry, Annika.
Is there specific trauma-induced postnatal anxiety counseling out there?
Oh, okay. So where we can refer women to.
Yes.
Yeah, so there is really good talking therapies. So if you Google IAPT or talking therapies, it's an NHS funded group where a woman can self-refer or GP refer, and it's done over the phone at the moment. It's a really good starting tool. It's free. It's all sort of borough run, so there's different numbers for the different boroughs, but it's a really good place to start. So talking therapies, and I've seen a lot of women that have undergone it following a debrief appointment that I may have with them in the postnatal period and refer them onto that. Yeah.
Thank you. And the last question from Charvani again. Does a regular monthly period mean that ovulation is happening for certain?
A regular monthly period. So that's generally yes, because obviously you get that sort of withdrawal bleed, you know, as you obviously ovulate, you don't fall pregnant, and then obviously it's that formation of the corpus luteum. What sometimes might happen though, and this is where it can be a little bit confusing, if say, you know, it's a woman who's got PCOS and she's of a higher BMI, it may be that she's got this sort of irregular menstrual shedding because the endometrium just, you know, and the progesterone, it may be that she's just shedding a little bit of an intermenstrual bleed, and a woman might actually think that's her period. So that's why it's looking at that whole picture. You know, there are obviously investigations one can do to see whether or not one is having that regular sort of monthly ovulation, and that's obviously looking at progesterone levels. You know, traditionally it's at day 21, but fertility specialists obviously have, you know, other realms and what they sort of trust in sort of, you know, tracking that ovulation.
Thank you, Jess. We're actually having quite a few more questions coming in, and if you don't mind, we still have time. Is that okay, Jess?
Yeah, of course, of course.
Yes. So Agni sent a question asking, can retroverted uterus have a negative impact on conception?
No, it's a good question. And actually women will say, oh, my uterus isn't retroverted. No, there's no evidence to suggest that will impact on one's ability to fall pregnant. We know, you know, as GPs and gynecologists, that retroverted sometimes makes examinations more difficult from a Pap smear point of view, but it most definitely doesn't impact on one's ability to fall pregnant.
Great. Susie asking the question, I'm interested to know if you think women are having children later and why you feel that is.
Oh yeah. So I guess it's an interesting one. I definitely feel that we possibly, you know, over the next while, we'll see, you know, the average age one chooses to have their first child increase a little bit more. And I do believe that will happen. I mean, I don't know what's going to happen with the COVID pandemic as well, because I think the COVID pandemic, you know, with job changes, potential redundancies, I think that's changed a lot of couples' long-term plans. So actually this pandemic itself over the last 12 months may have an impact. And I think we'll only really know that looking back of all these things that have evolved. Pre-pandemic, I think there was definitely a drive for you know, women entering their first pregnancy of an older age, in particular in London. And I think that's just on the basis of our demographics. You know, often people are in their occupations and delaying fertility for their own personal reasons. I personally don't think there's anything wrong with that. As I said before, you know, everyone has their own individual choices, and what we should be doing as a clinician is supporting them, and obviously just making sure that, you know, they're being safe in the decisions they make. What we know is, you know, delaying it too much, that obviously can in some instances reduce, you know, the spontaneous conception or reduce one's ovarian reserve. And I think that's, you've got to just keep that in the back of your background mind, because that, you know, in some women that can take away, you know, if they delay it too long, they may be left with no eggs, and so they do then get put down this pathway of assisted reproduction.
Thank you, Jess. And Hina asking, I'm getting quite a few female patients asking about freezing their eggs. Any advice to give them?
Yeah, that's a really good one to ask the next person who's speaking in a few weeks. So one of my fertility specialists, I believe, is doing the next talk. I also get asked that a lot, actually, by friends and patients as well that I see in my gynaecology clinic. You know, should I be thinking about it? And I think that's an interesting one. And I think that's when one has to think about their life. You know, maybe it is that they need to do that basic workup to, you know actually, you know, for instance, if someone's 35 and they're not planning on falling pregnant anytime soon, you know, do I need to be thinking about it? You know, what's my plans going forward? I don't think there's anything wrong with it. I actually think it's a great option that we have that now. But I think that's definitely one for the fertility specialist to answer. The reason I also saying that is it's interesting to hear the statistics of it. And I know from listening to my colleagues, you know, how many eggs can one collect? What are the chances if you freeze them that you can use them? And I think they're in particular questions that women need to know the answers for before they sort of go down that path, because it might be very different to what one perceives.
Yes, if you don't mind, I just comment on that, because we actually have really high level of inquiries about the same on the fertility. So we have loads of patients who are later at the later stage of their life, and let's say single professional woman, and they do think about freezing. So, you know, it was a really good question, but I think it relates to Susie's question as well, having children later. And unfortunately, that may lead to infertility, and woman thinks early, okay, I need to freeze eggs to make sure that I can have my child in a later stage.
Yeah, no, coming from Australia, it's very on trend there that women do it a lot earlier than here. So they sort of think about it early 30s. And the thing is, you can't think about it too late. That's the other thing. So it's a really good one to think about. And I think it'll become more and more common. Yeah.
There is, okay, this is the last question. It's an interesting one. I wonder, it's a very fertility related question. So we know that there's interesting fertility topics.
Yeah.
Helping. What's your experience with fertility issues and a woman with sickle cell disease?
Oh, so I can think of two colleagues here that come to mind. I am not a sickle cell disease expert at all, and so I have a colleague, Professor Otang, and I'm sure he'll be part of this series. But that from a sickle cell perspective, it's all about seeing the right person from that perspective, because sickle cell disease is a really unique disease. It's a really unique subset of women. Lots can happen. You can fall pregnant. You can have a pregnancy, and we see that because we've got a cohort of women at St Thomas's that have very good outcomes, but that's because they're looked after by a specialized colleague that, you know, knows sickle cell back to front, knows the surveillance that's required on these women, most definitely. So I feel like I'm batting that question onto someone else. But, it's not my area of expertise.
But yes, we're going to have Professor Otang to talk on one of the topics. But thank you very much, Jess. I'm going to hand it over to Monique to finish off the seminar. Thank you, Jess.
Thank you so much, Jess and Eniko. Thanks, those were really, really interesting questions. Thank you so much for everybody submitting those as well. And like Jess and Eniko were saying, we have got some really interesting upcoming webinars from some of our other consultants. So all of your questions can be answered further in detail as well, particularly those to do with fertility. We can get those a few more opinions from our other consultants. So just a quick bits to end off there, just in regards to the feedback survey. It will pop up just after the webinar. If you'd be so kind to just answer a few questions on there, that'd be fantastic. The certificate of attendance will follow within the next week. It will go to the email address that you registered for the tickets for on Eventbrite. If you haven't received it within a week, please do check your junk folder. And if not, please send us a message and we'll make sure we get that all sent over. If you do have any patients that you would like to refer to Jess, or in fact any other of our consultants at Guy's and St Thomas's Private Healthcare, please do get in contact with our private patients inquiries team, and they'll be more than happy to help and can send over all of the relevant information. And yeah, if you are interested in our upcoming webinars and all of our future events, please do join our mailing list by visiting our website, and it will also be sent in the follow-up email. Thank you so much, and we hope to see you next time on our next webinar. Take care. Bye-bye.